Welcome to the Deep Dive, the show where we cut through the noise and give you the most essential insights from the world's most critical information. Today, we're plunging into a topic that's, well, as dynamic as it is life-saving, the ever-evolving world of cardiovascular medicine, especially how it intersects with modern surgical practice and anesthesia. Think about patients undergoing non-cardiac surgery who already have complex heart conditions, perhaps even recent coronary interventions, requiring intricate management plans that demand truly expert coordination. Our mission with this deep dive is to be your shortcut to being genuinely well-informed, extracting those crucial nuggets of knowledge, so you can master this information like the elite professionals who navigate these complex cases every single day. Our focus for this journey is an in-depth exploration of autonomic and cardiac pharmacology as it relates to the perioperative period, all drawn directly from expert medical textbook excerpts. This isn't just theory, it's basically the bedrock of critical decision-making.
Absolutely. And this deep dive is so vital because delivering top-tier anesthetic care demands continuous, meticulous monitoring of all body systems, with an acute and really an unwavering emphasis on cardiovascular status. Imagine the profound stress that complex anesthetic plans combined with invasive surgical interventions place on a patient's cardiovascular balance. This isn't about guesswork. It requires incredibly precise manipulation of vital signs to ensure patient safety and, optimal outcomes. It's a constant, high-stakes balancing act.
So let's unpack how we keep that balance. Okay, first off, cardiovascular medicine is without a doubt one of the most rapidly changing specialties out there. It's like trying to hit a moving target. New management guidelines are being refined almost in real time as large-scale clinical trials report their findings. It gives you this incredible sense of continuous, relentless evolution in the field, always pushing the boundaries of what's possible.
Right. And this rapid evolution has profound practical implications for patients. We're seeing more and more individuals who have undergone complex coronary interventions, things like stents or bypasses, now needing non-cardiac surgery. These patients often arrive with incredibly intricate medication regimens, complex management plans. They absolutely necessitate close and continuous consultation with their cardiologists. It's truly a collaborative effort to ensure their safety.
That brings us directly to the anesthesia provider's critical role. It requires an almost intuitive, continuous monitoring of all the body's systems. But with that special heightened emphasis on the patient's cardiovascular status, it's not just a part of their job, it's really the core of what they do.
Precisely. Because, as you said, complex anesthetic plans and any invasive surgical intervention can produce immense stress on a patient's delicate cardiovascular balance. It's not about simply maintaining a baseline heart rate or blood pressure. It's about active, careful manipulation of vital signs to counteract those physiological stressors and maintain stability throughout the entire procedure.
Yeah, absolutely. And when you consider the sheer array of diagnostic tests, advanced monitors, and the vast pharmacological toolkit, all the grades available, it becomes crystal clear that a thorough, in-depth understanding of autonomic and cardiac pharmacology isn't just helpful, it's absolutely essential. It's the foundational knowledge that underpins every single decision made in the operating room.
Exactly. A well-devised treatment plan built on that deep pharmacological understanding is what allows the anesthetic course to flow smoothly and predictably, minimizing surprises. More importantly, comprehensive intraoperative planning with an eye not just on the surgery itself, but also on the immediate and even the late postoperative periods. That's absolutely critical for avoiding unforeseen complications or, untoward outcomes. It's about looking ahead to ensure a safe journey from start to finish.
So, when a patient comes in with a complex medical history and is already on a number of medications, there's this incredibly delicate balance required. It's about weighing the immediate anesthetic requirements against the need to maintain a successful continuum of therapy for that patient's long-term health. Especially if they're on multiple medications, it's truly a high-wire act of pharmacological integration, making sure everything works together.
What's truly remarkable here is how much continuous refinement is happening in this field. It's not just about treating illnesses, it's about proactively managing complex physiological states, constantly pushing the boundaries of what's possible in patient care.
This makes you wonder, how do we, as practitioners and informed individuals, keep up with this incredible pace of change and ensure optimal outcomes for such complex patients? The answer, of course, is a deep dive like this one, allowing us to distill and integrate this ever-evolving knowledge. Okay, let's transition into the specific pharmacological agents, starting with autonomic drugs, often called sympathomimetic amines. Think of these as the body's fight or flight activators, or maybe boosters. Right? They're used in a wide variety of critical situations, from anesthesia-induced low blood pressure and slow heart rate to severe allergic reactions like anaphylaxis, different shock states, heart failure, and even during cardiac resuscitation. Their applications are incredibly broad and frequently life-saving.
Right. At a fundamental level, sympathomimetic amines are designed to interact with the same receptors that your body's natural adrenaline and noradrenaline target. These are called adrenergic, and dopamine-adrenergic receptors. They're found throughout the body, influencing everything from your pupils to your heart and airways. Their specific effects, whether it's speeding up the heart or constricting blood vessels, depend on which of these receptors they primarily activate.
Yeah, and the effectiveness of any particular sympathomimetic amine isn't just about its presence. It depends heavily on how much of the drug reaches the receptor, how strongly it binds to specific receptors, and even how many receptors are available for it to interact with. This means that the physiological effects can vary dramatically, not just based on the drug dose, but also on the amount of natural stress hormones your body is already releasing. It's far from a one-size-fits-all effect.
Okay, let's start with epinephrine, also known as adrenaline. It's one of your body's naturally occurring fight-or-flight hormones, the final product in the complex chain of stress hormone synthesis. What makes epinephrine unique is its strong stimulation of both beta-1, that's heart-focused, and beta-2 vasodilation and bronchodilation receptors. Even at relatively low doses, this broad action sets it apart from norepinephrine, which has much less beta-2 activity.
And its wide clinical utility really reflects that versatility. Epinephrine is indispensable in treating severe allergic reactions like anaphylaxis and for CPR. Its unique combination of effects also makes it crucial for certain shock states, particularly when there's both poor tissue oxygen delivery and significant low blood pressure. It's especially useful when you need that simultaneous cardiac stimulation and broad vasodilation, or when patients aren't responding to other agents. The key thing to remember is that its alpha or beta effects can actually dominate depending on the dose.
Exactly. To elaborate on that dose relation, at lower doses, say around 10 micrograms per minute, epinephrine primarily works to redistribute blood flow. It sends more to skeletal muscle and generally lower systemic vascular resistance, or SVR. But as you increase the dose, the alpha effect starts to take over. This leads to widespread vasoconstriction, causing your blood pressure to rise significantly. You'll see the systolic pressure go up, while diastolic pressure stays relatively unchanged, leading to a noticeable widening of the pulse pressure. It's a powerful balancing act that, if not carefully managed, can lead to the heart working harder and potentially not getting enough oxygen itself, especially if there are existing blockages in the coronary arteries.
And beyond those dose-related effects on blood vessels, epinephrine's beta-1 effects on the heart are quite profound. We're talking about mark-positive inotropic actions increasing the force of the heart squeeze, chronotropic actions increasing heart rate, and dromotropic actions speeding up the electrical signals through the heart. It's a full-on cardiac boost.
But here's the crucial trade-off. With that powerful boost comes an increased demand for myocardial oxygen. As heart rate, the heart's workload, and its output all go up, so does the heart muscle's need for oxygen. This is a delicate balance, as increased electrical activity can also lead to arrhythmia. Vigilance is paramount. You have to ensure the heart's oxygen demand doesn't outstrip its supply. It's a bit of a paradox. Epinephrine can both increase the heart's demand and, if vasoconstriction is severe, potentially decrease the blood supply to the heart itself. However, it's worth noting that in low doses used to treat hypotension, it can actually improve coronary artery perfusion by increasing mean arterial pressure.
Right. On the other side of the coin, the beneficial beta-2 stimulation effects of epinephrine are also quite important. These include significant bronchodilation, which opens up airways, general vasodilation in some areas, and a stabilization of mast cells, which helps reduce histamine release. That's why it's so effective in severe allergic reactions.
And concurrently, the alpha stimulation that's also occurring promotes a decrease in bronchial secretions. So the overall effect in the airways is a substantial decrease in resistance, leading to improved oxygenation. However, that increased alpha effect seen with higher doses can also cause constriction of blood vessels in the kidneys and gut, potentially leading to decreased blood flow to these vital organs, which needs to be considered in specific clinical scenarios.
Epinephrine also has some significant metabolic effects. Its beta stimulation can activate the body's renin-angiotensin system, leading to increased breakdown of fats and stored sugars, and even inhibiting insulin release. This can cause a significant rise in blood sugar, something critical for anesthesia providers, especially in diabetic patients.
And there's a fascinating nuanced effect on potassium levels. Initially, epinephrine can cause a transient increase in potassium as it moves out of liver cells, followed by a longer period of low potassium, as the beta-2 stimulation forces extracellular potassium back into red blood cells. It's a two-phase shift that requires careful monitoring.
Next up, norepinephrine, often known as noradrenaline. This is a potent drug primarily used to raise blood pressure. While it's not quite as strong as epinephrine in stimulating alpha receptors at equal doses, it truly stands out for its minimal beta-2 activity, especially at lower doses. The net result is, for the most part, unopposed alpha stimulation, meaning it's really a pure vasoconstrictor focused on increasing systemic vascular resistance.
That pure vasoconstrictor action means you generally don't see the increased heart rate from beta-1 stimulation that you'd expect. Why? Because the significant increase in systemic vascular resistance triggers a reflex vagal response, essentially telling the heart to slow down. In terms of blood flow, while it can reduce flow to some vital organs, it can actually improve blood flow to the coronary arteries because it increases diastolic blood pressure, which is when the heart muscle gets its blood supply. However, it can increase resistance in kidney blood vessels, potentially leading to decreased urine output, and it also constricts veins, which can increase preload.
There's been a significant debate in critical care about whether norepinephrine or dopamine is a better first-line therapy for shock. A 2016 meta-analysis actually suggested they're equally effective in terms of outcomes, but it did note that dopamine tends to cause more side effects, specifically arrhythmias and possibly even an increased mortality rate. So while the debate continues, there's a leaning towards norepinephrine.
From a practical standpoint, norepinephrine is typically used in patients who have good cardiac output, but dangerously low systemic vascular resistance. Think of severe infection where blood vessels are just too relaxed. However, a word of caution. The intense peripheral vasoconstriction caused by norepinephrine, even if it brings blood pressure back to normal, can paradoxically worsen underlying problems with blood flow and oxygen delivery to peripheral tissues. It's a trade-off that demands careful assessment. Its metabolic effects are less pronounced than epinephrine's, and its adverse effects are primarily due to that intense vasoconstriction.
Let's turn our attention to dopamine. This is a naturally occurring neurotransmitter in your body. What's unique about dopamine pharmacologically is its truly dose-dependent stimulation of dopamine, beta, and alpha receptors. This allows for a range of targeted effects, depending on how much you administer.
Right, that dose dependency is key to understanding its use. At very low doses, generally less than 1 to 4 micrograms per kilogram per minute, you primarily see dopaminergic effects. This was historically thought to dilate renal arteries, increasing kidney blood flow and urine output. However, it's crucial to clarify that the actual benefits of this renal dopamine are now highly debated among many clinicians. Long-term patient outcomes haven't been shown to improve. At moderate doses, from 5 to 10 micrograms per kilogram per minute, the beta effects become predominant, influencing cardiac activity by increasing heart rate and contractility. And finally, at high doses, from 11 to 20 micrograms per kilogram per minute, alpha stimulation takes over, leading to widespread vasoconstriction. Dopamine also has an indirect effect, causing the release of your body's own norepinephrine.
It's important to remember that norepinephrine is now widely considered the first-line therapy for patients in septic or vasodilatory shock. And in cases of severe sepsis, some clinicians have found dopamine to be less effective, largely because the beta receptors in these patients can become desensitized or downregulated.
When dopamine is administered during surgery or anesthesia, especially for its intended kidney protective effects, vigilance is still paramount. There have been cases where dopamine was linked to severe limb ischemia, particularly if given through a peripheral thiamine. Doctors need to be extra careful, especially in children or patients with vascular diseases like diabetes or Raynaud phenomenon, or if an arterial line is in an affected limb. Other metabolic and CNS effects, similar to those seen with epinephrine but generally less extensive, have also been attributed to dopamine.
And when it comes to drug interactions, dopamine is broken down by enzymes called monoamine oxidase, or MAO. This means its effects can be significantly prolonged in patients who are already taking an MAO inhibitor for other conditions. Tricyclic antidepressants can also amplify the effects of sympathomimetic drugs, so careful consideration is needed when these drugs are co-administered.
Moving on to isoproterenol. This is a synthetic catecholamine, chemically similar to your body's natural stress hormones. It's a potent non-selective agonist of both beta-1 heart and beta-2 lungs and blood vessels receptors. But it notably has no activity at alpha receptors or dopamine receptors. It's purely a beta stimulant.
The effects are quite profound. Its strong beta-1 stimulation results in increased heart muscle contraction and faster heart rate. When combined with its peripheral beta-2-induced vasodilation, which lowers overall vascular resistance, you see a significant boost in cardiac output. This makes it a powerful cardiac stimulant.
However, with that powerful cardiac stimulation comes significant drawbacks. The intense positive effects on heart rate and contractility dramatically increase the heart muscle's oxygen consumption. This increased demand can be severely compromised by the beta-2-induced peripheral vasodilation, which lowers the diastolic blood pressure, ultimately reducing blood flow to the heart's own coronary arteries. These effects are particularly detrimental and dangerous in patients with existing coronary artery disease. Excessive tachycardia, the potential to induce myocardial ischemia, and the production of dangerous arrhythmias are major factors that limit its use.
Despite those limitations, isoproterenol does have specific niche clinical uses. It's occasionally employed for very slow heart rates associated with heart block, or for a specific type of ventricular tachycardia called torsades de pointe. It's also used after heart transplant to help maintain heart rate. Beyond its cardiac uses, it's a potent bronchodilator and helps relax blood vessels in the lungs.
Next, let's discuss dobutamine. This is another synthetic sympathomimetic amine, a modification of isoproterenol, but it has much more widespread clinical use. Dobutamine primarily acts as a beta-1 agonist, with only mild beta-2 effects.
This distinct receptor profile means dobutamine induces a strong inotropic response and increased force of cardiac contraction, but with minimal chronotropy, meaning it doesn't significantly increase heart rate. The beta-2 receptors located on blood vessels produce a vasodilatory effect, which leads to a decrease in overall vascular resistance and a slight drop in blood pressure. However, the resulting increase in cardiac output usually compensates for this decrease in resistance, causing the blood pressure to either increase or at lower doses remain relatively unchanged. You also see a decrease in pulmonary artery pressure and an increase in the left ventricular stroke work index, indicating improved cardiac efficiency.
These positive inotropic effects, coupled with the lack of significant heart rate increase and the maintenance of relatively stable blood pressure, have made dobutamine an option in specific types of shock, like cardiogenic and septic shock, as well as in select patients with mild heart failure. It is also frequently used during cardiac stress testing to assess heart function. However, it's crucial to note that recent evidence indicates significant adverse effects when dobutamine is used in cardiac surgery. This has led many clinicians to actually stop using it for inotropic support in that specific surgical setting.
Right, that's an important clinical shift. But let's focus on phenylephrine, also known as neosynephrine. This is arguably the most commonly used pure alpha agonist in clinical practice, especially in anesthesia. It boasts strong alpha-stimulating effects with virtually no beta-receptor stimulation, making it a highly selective vasoconstrictor, primarily focused on tightening blood vessels.
Exactly. The primary effect of phenylephrine is a sharp rise in blood pressure, which is a direct result of a significant increase in peripheral resistance due to its alpha-1 stimulation. A common, predictable response to this is a reflex bradycardia, a flowing of the heart rate, as the body tries to compensate for the sudden increase of blood pressure. Because of its potency, careful, precise titration of intravenous phenylephrine is absolutely necessary to avoid large, abrupt changes in blood pressure and undesirable decreases in heart rate. Its onset of action intravenously is immediate, and its duration typically ranges from 5 to 20 minutes.
Given its potent vasoconstricting effects, phenylephrine has diverse clinical uses. Topically, it's used to prevent nosebleeds during nasal intubation or to reduce bleeding during ear, nose, and throat surgeries. It's also used in ophthalmology to dilate pupils, but it's critical to caution that severe hypertension can occur if not carefully dosed, so judicious use and titration are paramount.
Moving on to ephedrine. It's a synthetic sympathomimetic commonly used in anesthesia. What's unique about ephedrine is its dual mechanism. It directly stimulates both alpha and beta receptors, and it also indirectly causes the release of your body's own stress hormones from nerve endings. This results in both central and peripheral actions, contributing to its broad effects.
Its effects are similar to epinephrine, but generally more moderate and, importantly, are not accompanied by the dramatic increase in blood sugar concentrations that you might see with epinephrine. Ephedrine also has a longer duration of action thanks to its chemical structure, which makes it resistant to certain enzymes that break down other stress hormones.
Ephedrine consistently produces dose-related increases in blood pressure, cardiac output, heart rate, and systemic vascular resistance. It's often chosen as the first agent to alleviate hypotension. especially when that low blood pressure is caused by the heart-depressing effects of anesthetic agents or the vasodilation from spinal anesthesia. When given intravenously, typically in doses ranging from 5 to 25 milligrams, ephedrine has an immediate onset and a duration of action usually between 15 minutes to 1.5 hours.
It's important to use this drug cautiously, especially in patients with questionable blood flow to the heart. The reason is that the heart muscle's oxygen consumption may increase more dramatically than anticipated due to ephedrine's effect on heart contraction, potentially leading to ischemia. Additionally, ephedrine also causes bronchodilation due to its beta-2 receptor activation in the lungs, which can be a beneficial side effect in some contexts.
This brings us to a significant controversy, especially in obstetrics. Ephedrine had long been considered the go-to drug to address low maternal blood pressure after regional anesthesia during childbirth, primarily because it was believed to maintain uterine blood flow better than phenylephrine. However, newer data, particularly from 2020, are questioning this long-standing practice. Phenylephrine is now increasingly recommended over ephedrine in this setting. The concern with ephedrine is that it can increase the fetal metabolic rate, potentially leading to fetal acidosis, an effect that phenylephrine does not share.
Interesting. And as with any indirect acting agent, a phenomenon called tachyphylaxis may develop with subsequent dosing of ephedrine. This means you might need higher doses to get the same effect because the body's endogenous stress hormone stores can become depleted after repeated use.
Shifting focus to selective beta-2 agonists. Examples include widely recognized inhalers like albuterol and long-acting formulations like salmeterol and formoterol. Their primary clinical utility lies in effectively treating obstructive airway diseases, such as asthma, COPD, and acute bronchospasm.
The advantage of their selectivity for beta-2 receptors is that it leads to the desired response of bronchodilation opening up the airways, while minimizing the undesired beta-1 responses, like a fast heart rate and arrhythmias. However, it's important to acknowledge that none of these agents are completely selective. They are widely available in aerosol form, and it's well accepted that this delivery method is highly effective.
These drugs also boast an increased duration of action, a benefit of their chemical structure, which makes them resistant to certain enzymes that break down other stress hormones. This extended action is useful, for instance, in preventing exercise-induced asthma.
However, there are risks with chronic use. Long-term administration can lead to tachyphylaxis, a diminished response, because of a reduction in the number of beta receptors in the body. There's also been a suspicion of increased airway hyperresponsiveness with chronic use. Due to these concerns, a black box warning was added to the package inserts of all preparations containing a long-acting beta-2 agonist, highlighting a higher risk of asthma-related death. The recommendation now is that if long-acting beta-2 agonists are needed, it's safer to give them in combination inhalers with inhaled corticosteroids.
It's also worth briefly mentioning their past use for delaying premature labor, a tocolytic effect, by relaxing the uterus. However, their use for this purpose has declined dramatically due to a high frequency of side effects and a noted lack of efficacy. Separately, mirabegron, a beta-3 agonist, is used for overactive bladder.
Now let's explore alpha-2 agonists, starting with clonidine. This is a presynaptic alpha-2 agonist, meaning it acts on receptors located on the nerve endings themselves.
Right. Clonidine lowers blood pressure through a dual mechanism. Firstly, by acting on peripheral alpha-2 receptors, it inhibits the release of stress hormones, leading to vasodilation. Secondly, and considered its main antihypertensive mechanism, it stimulates central alpha-2 receptors in the brain. This results in diminished sympathetic outflow from the central nervous system, leading to a decrease in circulating stress hormones and other pressure-regulating substances. It's usually reserved for short-term oral treatment of severe hypertension as an add-on drug.
A major concern with clonidine, which is critical to remember, is rebound hypertension if it's abruptly discontinued. This can manifest as a significant surge in stress hormone levels, leading to a fast heart rate and dangerously high blood pressure. Therefore, continuing the medication throughout the perioperative period is absolutely essential unless a very careful tapering process is undertaken. Transdermal patches can also be used during surgery to ensure continuous delivery and prevent withdrawal symptoms. Beyond its primary use for hypertension, clonidine is also used as a sedative before surgery, as an analgesic when combined with opiates for severe pain, and to help suppress alcohol withdrawal symptoms.
Next, dexmedetomidine, an alpha-2 agonist marketed for short-term sedation in critical care, is frequently used as an adjunct to anesthesia in various situations.
Dexmedetomidine provides dose-dependent sedation, pain relief, and anxiety reduction. Crucially, it does so without producing significant respiratory depression, which is a major advantage in many clinical scenarios. However, its side effects are predictable from its pharmacological profile, and they include low blood pressure, slow heart rate, oversedation, and a potentially delayed recovery.
Despite its unique properties, it's vital to note current guideline recommendations for perioperative use. The ACAAEA 2014 guidelines are quite clear. Alpha-2 receptor agonists are not recommended for the prevention of cardiac events. Similarly, the ANESTHESIA guidelines state that alpha-2 receptor agonists should not be administered to patients undergoing non-cardiac surgery. These are strong recommendations against their routine prophylactic use in that specific context.
Okay, let's move to alpha receptor antagonists, or alpha blockers.
Alpha blockers are employed in a variety of clinical scenarios. They're used to treat high blood pressure, benign prostatic hyperplasia, BPH, for urinary symptoms, pheochromocytoma, and even conditions like Raynaud phenomenon and certain toxicities.
Common side effects associated with alpha blockers include orthostatic hypotension, that sudden drop in blood pressure upon standing, and a reflex tachycardia, where the heart rate increases to compensate. These effects can make them somewhat challenging to use for hypertension in ambulatory patients. Additionally, because some alpha receptor antagonists have a significantly longer duration of action, other agents are often preferred for rapid, emergent blood pressure control.
Let's delve into specific alpha blockers, starting with phenoxybenzamine. This drug works by binding irreversibly to alpha receptors. This means its action isn't simply overcome by more adrenaline. Its effect only ends when the body metabolizes the drug and then generates new alpha receptors, which can take a considerable amount of time, days even. Clinically, this drug is primarily used preoperatively in patients with pheochromocytoma to help control their extreme responses to endogenous stress hormones. It's typically started 1 to 3 weeks before surgery.
Phenoxybenzamine also has a unique interaction with other sympathomimetics, sometimes called epinephrine reversal. It prevents the expected blood pressure rise from drugs like phenylephrine. With norepinephrine, its effects are limited to mild cardiac stimulation. But with epinephrine, phenoxybenzamine can actually lead to an enhanced drop in blood pressure and increased heart rate because it unmasks epinephrine's beta-2 vasodilating effects. The primary side effect to watch for is orthostatic hypotension, and nasal stuffiness is also frequently associated with its use.
Next, phentolamine is a competitive antagonist of both alpha-1 and alpha-2 receptors. It stands out from phenoxybenzamine because of its rapid onset after intravenous administration and a much shorter duration of action. It can be used for the short-term control of high blood pressure in patients with pheochromocytoma, or it's proven useful in treating local infiltrations of vasoconstricting agents. If a drug like norepinephrine leaks out of the vein, phentolamine can be injected directly into the site to reverse localized constriction.
Moving on to prazosin and other selective alpha-1 antagonists, this group includes drugs like prazosin, doxazosin, and terazosin. They are selective alpha-1 antagonists primarily used in the treatment of chronic hypertension and BPH. Their key advantage is that they don't block alpha-2 receptors, which means they don't interfere with the body's natural braking system on stress hormone release. This often results in less of the reflex fast heart rate seen with non-selective alpha antagonists.
These drugs cause vasodilation in both arteries and veins, which lowers overall resistance, the amount of blood returning to the heart, and the workload the heart has to pump against. They're typically taken orally, and orthostatic hypotension, especially with the first dose, can be a major side effect. Other alpha-1 selective antagonists like tamsulosin are particularly effective at relaxing the smooth muscle around the bladder, neck, and prostate, helping to relieve obstructive urinary symptoms in BPH patients. Because these newer selective agents specifically target alpha-1 receptors and don't affect beta receptors, there's a decreased risk of hypotension.
However, there's an important side effect associated with tamsulosin and other alpha antagonists, floppy iris syndrome. This can complicate cataract surgery. While it's a concern, discontinuing them prior to surgery is generally not required as long as the ophthalmologist is aware of their use.
Finally, within alpha receptor antagonists, we have droperidol, a drug that used to be a common antiemetic in anesthesia. Its mechanism involves both dopamine and alpha-adrenergic blockade, which can lead to small reductions in blood pressure, particularly in volume-depleted patients.
The use of droperidol has decreased markedly due to a significant FDA black box warning on its package insert. Its use has been associated with prolongation of the QT interval on an electrocardiogram, which can significantly increase the probability of developing torsades de pointes, a serious and potentially fatal heart rhythm. While there's been much debate about whether very low doses for antiemetic purposes carry the same risk, the overall concerns about patient safety and legal implications have led to a drastic change in its use. The FDA now even requires an ECG prior to its administration. It's a good example of how safety data can fundamentally alter clinical practice. Now let's talk about beta-adrenergic blocking agents, or beta blockers. These are among the most widely prescribed drugs globally, and for good reason. Their clinical applications are incredibly broad, covering a vast range of cardiovascular conditions and more.
Absolutely. Common applications include treating angina pectoris, high blood pressure, managing patients post-MI, and various supraventricular tachycardias, including WPW and atrial fibrillation. They're also used to suppress increased sympathetic activity, for instance, during intubation and in managing hypertrophic obstructive cardiomyopathies in CHF. Beyond the cardiac uses, they treat migraine headaches and are crucial in preparing hyperthyroid patients for surgery. They also help prevent the detrimental effects associated with cardiac remodeling.
Their mechanism of action is quite elegant. Beta blockers are structurally related to isoproterenol, and they work by competitively binding to beta receptors, effectively blocking the actions of catecholamines and other beta agonists. Because they are competitive antagonists, their blocking actions can actually be overcome by sufficient agonist concentration. It's a constant tug of war for that receptor.
Right. Beta blockers are typically subdivided based on their selectivity for cardiac beta-1 receptors, as well as other differences like vasodilation or partial agonist activity. The degree of receptor selectivity is profoundly important. Beta-1 antagonism leads to desired effects like a lowered heart rate, decreased myocardial contractility, and diminished AV conduction velocity. It also reduces myocardial oxygen consumption and treats arrhythmias.
Contrast this with beta-2 antagonism, which can cause adverse effects like bronchoconstriction, hypoglycemia, and peripheral vasoconstriction. Crucially, note that selectivity diminishes as the dose of selective beta blockers increases. They can start affecting beta-2 receptors more broadly.
Some beta blockers possess what's called intrinsic sympathomimetic activity, or ISASA. Think of these as partial agonists. They don't stimulate beta receptors as much as full agonists, so they act as competitive antagonists in the presence of full agonists, like during maximal sympathetic tone. ISA minimizes bronchoconstriction risk in patients with reactive airway disease who need beta blockade. Pindolol is a good example.
And some beta blockers have membrane stabilizing activity. This property, seen in drugs like propranolol, can diminish arrhythmogenicity by exerting a quinidine-like effect, though usually only at high drug concentrations.
We also have mixed beta and alpha receptor antagonists like labetalol and carvedilol. Their alpha receptor blockade makes them vasodilators. And abivalol is a newer cardioselective beta blocker with unique nitric oxide-mediated vasodilating properties.
Despite their widespread benefits, beta blockers do come with potential problems. Bronchospasm, overt cardiac failure in high-risk patients, potentiation of peripheral vasoconstriction in PVD, masking hypoglycemia signs in diabetics, impaired ability to increase serum glucose, elevated serum potassium levels, and significant impact on blood pressure if heart rate is critical for maintaining cardiac output.
A critical concept about beta receptors is their lability. They are subject to significant up and down regulation. Long-term therapy leads to upregulation and increased number and sensitivity of receptors. This is suspected as the cause of the severe withdrawal syndrome, seen with abrupt discontinuation, increased sympathetic activity for up to 2 days. This is precisely why patients receiving beta blockers must continue them without interruption perioperatively.
Okay, let's discuss 3 IV beta blockers useful perioperatively: esmolol, metoprolol, and labetalol. Esmolol has largely replaced older agents in many anesthesia settings due to its incredibly rapid onset, about 2 minutes, and very short duration, 10 to 15 minutes. This makes it easily and reliably titratable, with an elimination half-life of around 9 minutes.
For dosing, a typical IV loading dose is 500 ml/cd kilogem, followed by an infusion of 100-300 ml/cd kilogem. Small boluses of 10-20 milligrams can also be given. Esmolol is uniquely metabolized by enzymes in red blood cells. Metoprolol is commonly used after MI or for angina and hypertension once the patient is stable. IV dosing is 5 milligram as doses at 5-minute intervals up to a maximum of 15 milligrams.
And then we have labetalol. It's a non-selective beta blocker, but unique for its alpha blocking component in a beta-alpha ratio of about 7.1. This produces vasodilation. This dual action can be extremely beneficial when an acute rise in blood pressure could be devastating.
The usual IV dose is 0.25 milligram kilogram, repeatable every few minutes, or followed by an infusion at 2 milligram. In practice, often a bolus of 5-10 milligrams is titrated. Duration is 2-6 hours. Because it blocks beta receptors, pre-existing bradycardia is generally a contraindication for acute hypertension management. Importantly, it is recommended for hypertensive episodes in pregnant patients, as it typically doesn't affect uterine blood flow. It's metabolized in the liver and eliminated by the kidneys.
This brings us to a major ongoing controversy: the prophylactic use of beta blockers around surgery. The studies have been conflicting, and it's been a really hot topic.
Indeed. The POISE trial initially suggested cardiac protection in coronary heart disease patients. However, it also revealed a significant increase in all-cause mortality, particularly in septic or hypotensive patients, and an increase in strokes attributed to hypotension. Low blood pressure and slow heart rate were much more frequent in the beta-blocked group. While some subgroups, like high-risk or strictly titrated patients, might benefit, the increased mortality risk led to a significant reappraisal. Beta blocker initiation dropped sharply after mid-2008.
This shift led to new guidelines. The 2014 ASEA and ANAESTHESIA guidelines offered similar guidance. Both sets strongly recommend continuing beta blockers in patients already taking them. They also recommend considering starting them in patients with known ischemic heart disease or ischemia and those with multiple cardiac risk factors.
However, the efficacy ag guidelines suggest initiating them in patients with a compelling indication, but no other risk factors is of uncertain benefit. Both guidelines stress starting therapy well in advance of surgery, ideally weeks before. They emphasize the possibility of harm if started too late. The SAG considers starting on the day of surgery potentially harmful. While beta blockers may reduce perioperative MI risk, this comes with increasing stroke risk, and there's no evidence for a reduction in overall mortality. In patients without very high MI risk, beta blockers probably increase risk. Whether it's helpful to start them before surgery in intermediate to high-risk ischemia patients remains unclear due to insufficient data. Any benefits are more likely when initiated at least 1 week prior at a low dose, titrated to a heart rate of 55-70 BPM. It's prudent to avoid starting immediately before emergency surgery or in patients with prior stroke or sepsis, but crucial to continue in patients already taking them.
Despite the controversy in non-cardiac surgery, beta blockers still play a pivotal role in cardiac surgery. They substantially reduce postoperative supraventricular arrhythmias. However, their influence on mortality, MI, stroke, CHF, hypotension, and bradycardia in this specific cardiac surgery setting remains unclear.
In non-cardiac surgery, the evidence from well-conducted trials clearly shows an association with increased all-cause mortality and increased stroke rate. It appears the reduction in arrhythmias and MI is offset by potential increases in mortality and stroke. For these reasons, beta blockers are explicitly contraindicated in patients with asthma, bradyarrhythmias, acute heart failure, or advanced heart block. Researchers also explored alpha-2 agonists like clonidine or dexmedetomidine. However, studies found low-dose clonidine did not reduce serious cardiac events, but increased risk of hypotension and non-fatal cardiac arrest. As we noted earlier, guidelines are clear. Alpha-2 agonists are not recommended for preventing cardiac events or for patients undergoing non-cardiac surgery.
Now, let's touch on some other drugs affecting the sympathetic nervous system, starting with catecholamine-depleting agents like reserpine. These are rarely seen now.
Reserpine works by blocking the storage of catecholamines into vesicles, leaving them exposed to breakdown. This depletion is responsible for its antihypertensive action.
Next, tyrosine hydroxylase inhibitors, with metarosine as an example.
Tyrosine hydroxylase controls the first step in making catecholamines. Inhibiting it decreases circulating levels. Metarosine is primarily an add-on drug for blood pressure control in pheochromocytoma.
And finally, catecholomethyltransferase, COMT, inhibitors, like tolcapone and entacapone, used primarily for Parkinson's disease.
They block COMT, enhancing levodopa's action. However, a crucial concern is their potential to interact with cardiac drugs by slowing their metabolism. So caution is needed, and reduced initial doses considered when giving sympathomimetics like dobutamine, dopamine, norepinephrine, and epinephrine to patients on COMT inhibitors.
It's really fascinating to understand these more nuanced mechanisms. It's not just the direct action, but the ripple effects.
Exactly. It highlights the importance of knowing broader systemic interactions and the need for vigilance, especially in the dynamic perioperative setting.
Let's shift our focus to other classes of inotropic agents. Drugs influencing heart contractions, but through mechanisms beyond the traditional catecholamines.
Let's start with arginine vasopressin. This is an endogenous hormone, naturally produced in the brain. It's released when the body senses increased blood concentration or low fluid volume, playing a key role in controlling water balance, also known as antidiuretic hormone.
Its clinical relevance has grown significantly, particularly in critical care. Vasopressin deficiency and reduced receptor numbers are actually quite common in septic shock, which explains why it's become a therapeutic target.
Despite being a potent vasoconstrictor, vasopressin uniquely selectively dilates blood vessels in the kidneys, lungs, and brain. Low-dose infusion, typically 0.03–0.04 unitsmin, increases blood pressure, urine output, and kidney function. It can even decrease the norepinephrine dosage needed in septic shock. It's mostly used as an add-on therapy, allowing other vasopressors to be titrated down.
Interestingly, a randomized trial found adding low-dose vasopressin to norepinephrine wasn't significantly better than norepinephrine alone, though it might still be useful in less severe shock.
However, like any potent agent, vasopressin has potential complications: GI ischemia, decreased cardiac output, skin necrosis, even cardiac arrest, especially at doses 0.04 unitsmin. Careful titration is essential.
Okay, now let's turn to phosphodiesterase inhibitors, PDE inhibitors.
Specifically, phosphodiesterase 3, PDE3 inhibitors, also known as non-glycoside non-catecholamines. Milridone is a prominent example. They differ structurally and functionally from catecholamines and are generally used as alternatives or adjuncts in cardiac surgery and heart failure.
To understand them, remember phosphodiesterases break down crucial signaling molecules like CAMP or cGMP inside cells, essentially dampening these messages.
And this is where milrinone steps in. It prevents the breakdown of CAMP, enhancing its action. Milrinone uniquely increases heart contraction force and causes vasodilation without significantly increasing heart rate. Hence, it's sometimes called an inodilator. Cellularly, it improves heart pumping by helping muscle cells store and use calcium more efficiently.
One of milrinone's key advantages is that it retains its effect even when patients are on beta blockers or when receptors are desensitized, common in heart failure. So PDE3 inhibitors can actually boost the effect of other inotropes like dobutamine or dopamine, a powerful synergy.
Clinically, milrinone has shown benefits, like improving weaning from cardiopulmonary bypass after heart surgery. It enhances diastolic function, increases cardiac output, and decreases lung pressures. Its vasodilatory mechanism is distinct. In smooth muscle, increased CAMP causes calcium efflux, leading to relaxation and vasodilation, decreasing both preload and afterload. This, coupled with no heart rate increase, likely means no increase in myocardial oxygen consumption, a significant benefit.
However, like any powerful drug, milrinone is not without side effects, specifically arrhythmias, requiring careful monitoring.
Its elimination is primarily via the kidney, so caution is needed in renal failure patients due to the risk of life-threatening arrhythmias if it accumulates. It's typically given as a slow IV loading dose to avoid hypotension, followed by a continuous infusion, carefully adjusted.
Briefly, we should also mention sildenafil, known as Viagra, but also marketed as Ravacio. This is a PDE5 inhibitor.
Sildenafil produces vasodilation and is specifically used to treat pulmonary arterial hypertension. By relaxing lung blood vessels, it reduces the right heart's workload and improves symptoms of right-sided heart failure.
What's fascinating here is the sheer ingenuity in targeting different biochemical pathways to achieve similar yet nuanced effects, especially without relying on the adrenergic system.
Absolutely. It highlights how a deeper understanding of cellular mechanisms allows for precision medicine, offering solutions even when traditional approaches are limited.
Let's move on to the class of direct vasodilators. We'll focus on three common ones: sodium nitroprusside, nitroglycerin, and hydralazine. All three produce direct vasodilation, but with crucial distinctions in where they primarily act.
Indeed, sodium nitroprusside relaxes both arterial and venous vessels, offering a balanced effect. Nitroglycerin, in contrast, has a greater effect on venous relaxation, primarily influencing preload. Hydralazine primarily relaxes arterial vessels, affecting afterload more significantly. The mechanism for all three is believed to involve an increase in vascular nitric oxide, NO, though this isn't fully confirmed for hydralazine.
Their general clinical utility is broad. Nitroprusside and nitroglycerin are often used for controlled hypotension under anesthesia to reduce blood loss. Hydralazine is used with another drug for systolic heart failure, especially in Black patients, and as an alternative for those intolerant to angiotensin antagonists.
Let's look closer at sodium nitroprusside. It's used for emergent hypertension control, inducing hypotension for surgery, and acute cardiac disorders.
What makes it unique is its incredibly rapid onset within seconds and short duration, 1 to 3 minutes. This allows for exceptional moment-to-moment control.
Hemodynamically, it reduces both afterload and preload, decreasing filling pressures and increasing stroke volume and cardiac output. This leads to decreased left ventricular volumes and wall tension, contributing to decreased myocardial oxygen consumption.
Administration usually starts as an infusion at 0.3 millisecond regimen, titrated up. Rates rarely exceed 3 millicitylregimen, though maxima exist. Because of its potency, it's mixed with 5% dextrose, the bottle and tubing must be covered, light causes decomposition, and an infusion pump must always be used due to potency and cyanide toxicity risk. Cyanide toxicity is indeed a critical risk, essential to understand.
Nitroprusside contains 5 cyanide ions released upon metabolism. While the body has protective mechanisms, toxicity results when cyanide generation overwhelms elimination. This typically happens with high doses, 500 mg/regimen, administered faster than 2 mg/regimen, or chronically above 0.5 mg/regimen.
Clinical signs are crucial. Metabolic acidosis, increased mixed venous oxygen content, tachycardia, and tachyphylaxis, needing more drug for the same effect. Red flags.
Treatment is urgent. Stop infusion, give oxygen, treat acidosis. Specific antidotes include sodium nitrite, sodium thiosulfate, vitamin B12, hydroxycobalamin is very effective, and methylene blue.
Now, nitroglycerin, widely used for angina, ischemia under anesthesia, and blood pressure lowering. Rapid onset, short duration, easily titratable.
Its primary mechanism is venodilation, relaxing veins, increasing capacitance, decreasing preload. This lowers filling pressures, lessens wall tension, decreases oxygen requirements. Preload reduction is key for angina relief. It can also dilate larger coronary vessels, redirect flow to ischemic areas, and relieve coronary spasm. Arterial dilation can occur at higher concentrations.
For acute angina, sublingual nitroglycerin is most efficient. Relief in 1 to 2 minutes lasts up to 30 minutes. 4-E-nitro also has rapid onset, short duration.
It's extensively metabolized in the liver. Half-life only 3 minutes. 4-V-nitro is used for unloading the heart in CHF and MI. Guidelines suggest IV infusions after sublingual doses fail in STEMI patients, starting typically at 10-20 mg as titrated.
Compared to nitroprusside for controlled hypotension, it's less effective, and BP decrease is more volume-dependent due to its main effect on venous capacitance.
Contraindications include very low BP, 90 millimere HT, slow, 50 BPM, or fast, 100 BPM heart rate, and right ventricular infarction.
Specific anesthetic relevance. Its ability to relax biliary tract smooth muscle, relieving narcotic-induced biliary spasm. Often prepared as 50 milligrams and 250 millirel D5W.
Next, hydralazine, which directly relaxes arterial smooth muscle.
Administered intravenously for hypertension control, typically in doses from 2.5 to 20 milligrams.
Tachycardia often accompanies the BP decrease, secondary to preferential afterload reduction. Remember, it's variable onset, 2 to 20 minutes depending on anesthesia depth. Allow adequate time before repeat dosing to prevent profound BP drops. The limitation half-life in plasma is 1 hour, but vasodilating action lasts much longer, up to 12 hours.
It's metabolized in the liver. Acetylation involved slow acetylators prone to drug-induced lupus chronically and excreted by the kidneys.
Hydralazine is specifically used for hypertensive episodes during pregnancy.
So what does this all mean for the patient? It's about understanding the specific type of vasodilation needed and the potential pitfalls of each agent.
Exactly. And this raises the question, with such potent agents, how do we ensure optimal safety and efficacy in rapidly changing clinical scenarios?
Let's introduce calcium channel blockers, or CCBs, incredibly useful agents across a wide range of conditions.
Absolutely. Uses include angina, hypertension, arrhythmias, peripheral vascular disease, esophageal spasm, cerebral vasospasm, and controlled hypotension.
They fall into 3 main chemical classes. 1,4 dihydropyridines like nifedipine, benzothiazepines, diltiazem, and phenylethylamines.
Verapamil.
All CCBs generally have negative inotropic force and chronotropic rate actions. They are class 4 antiarrhythmics, blocking calcium channels, depressing SA and AV node impulses. They also produce coronary and systemic vasodilation with variations among drugs. To really get it, let's dive into the mechanism. Depolarization of the SA and AV nodes depends on inward calcium flux during the action potential.
CCBs block these channels, diminishing calcium influx, prolonging phase 2, exerting a negative chronotropic effect. Ventricular pacemakers depend more on sodium, minimally affected by CCBs, so CCBs are effective for atrial tachyarrhythmias.
This is why verapamil and diltiazem are common antiarrhythmics, effective for atrial tachyarrhythmias, including WPW, and controlling ventricular response and AF flutter.
Important distinction, though. Verapamil is not indicated for AF with WPW, nor always for simple atrial tachycardia. Beta blockers might be better there.
Their negative inotropic effect is beneficial in angina. Contractility depends on calcium influx, slowed by CCBs, decreasing myocardial oxygen consumption.
And their vasodilatory action. CCBs relax vascular smooth muscle. Systemic vasodilation of arteries and veins decreases preload and afterload, increasing cardiac output, decreasing myocardial work and oxygen consumption. This negative inotropy and vasodilation explain their antihypertensive effect.
Coronary arteries are also affected, increasing coronary blood flow. Particularly beneficial in preventing coronary artery spasm, like Prinzmetal angina.
Let's look at specific agents. Nimodipine is a long-standing treatment for cerebral vasospasm, often after ruptured aneurysms. It's the only FDA-approved oral agent for this.
It's a dihydropyridine thought to inhibit calcium channels in arterial smooth muscle, causing vasodilation, especially in the brain. Other agents are sometimes used for chemical angioplasty too.
Verapamil can be given IV, 2.5 to 10 milligram, repeatable, for atrial tachyarrhythmias.
Onset up to 10 minutes, duration 2 to 4 hours. Hepatically metabolized, renally eliminated. It's been largely replaced by adenosine as first line for SVTs due to adenosine's faster onset, shorter duration.
And nicardipine is useful as an IV preparation for perioperative hypertension.
And a newer one, clevidipine, Clevipre, is a dihydropyridine L-type CCB indicated as an IV antihypertensive.
What's key about clevidipine is its high selectivity for vascular muscle. It does not significantly affect myocardial contractility or conduction. Its effect is largely due to arterial vasodilation. Rapidly metabolized by blood esterases, half-life 15 minutes. Formulated as a lipid emulsion, needs careful handling. Dosing starts low, 1 to 2 milligraders, titrated up. Onset 2 to 4 minutes, duration 5-15 minutes. Highly titratable.
So while CCBs are useful, potential issues include varying degrees of AV block, myocardial depression, and hypotension.
And critically, an additive effect should be anticipated if used with other cardiodepressant agents like anesthetics. Requires careful titration and vigilance.
Okay, let's unpack this concept further, because understanding how these drugs affect calcium channels at a cellular level is key to their diverse applications.
What stands out to you about the versatility of this class? How they allow such targeted interventions in the cardiovascular system?
Let's shift focus again, this time to the powerful drugs interacting with the renin-angiotensin system, RAS, the body's key pressure regulators.
Let's start with angiotensin-converting enzyme, ACE inhibitors. Widely prescribed for hypertension, angina, diabetic neuropathy, CHF, and post-MI management. Foundational drugs.
Their primary action is inhibiting angiotensin-converting enzyme, ACE, often described along with ARBs as angiotensin axis-blocking drugs, AABs.
Okay, a concise RAS overview. Renin, from kidneys, response to low BP, converts angiotensinogen from liver to angiotensin I. ACE, mainly in lungs, converts angiotensin I to angiotensin II. Angiotensin II is a potent vasoconstrictor, also stimulates norepinephrine and aldosterone release. End result: increased peripheral vasoconstriction, higher BP, lower CO, and higher aldosterone, sodium water retention, potassium secretion. ACD inhibitors block the ACE step, preventing angiotensin II formation, producing vasodilation.
Enalapril is an example, a prodrug metabolized to active enalaprilat, available for but rarely used perioperatively. All ACE inhibitors are renally eliminated, half-lives prolonged in kidney compromise, requires dose adjustment.
Adverse effects: cough, up to 25%, common reason for stopping. Angioedema, renal failure, hyperkalemia, neutropenia, proteinuria. The dry cough is because ACE also metabolizes bradykinin. Blocking it leads to bradykinin buildup.
If an ACE inhibitor isn't tolerated, an ARB is usually substituted.
Which brings us to angiotensin II, receptor blockers, ARBs. Useful for hypertension and CHF, similar actions to ACE inhibitors.
But their mechanism is distinct. Competitive blockade of type 1 angiotensin II, AT1 receptors. Angiotensin II is made but can't bind effectively.
Key advantage: effective blood pressure lowering without the cough and angioedema of ACE inhibitors. They don't affect bradykinin breakdown.
No 5-reps currently marketed, often reserved for patients intolerant to ACE inhibitors.
Now the big controversy: anesthesia management of patients taking angiotensin axis blockers, ABEs.
Yeah, whether ACE inhibitors or ARBs should be withheld the morning of surgery. Most cardiac meds are continued, but these are debated.
The main concern: ADs may cause refractory hypotension during induction maintenance if not stopped, usually within 30 minutes of induction, worse with diuretics.
Conflicting arguments. Withholding might decrease intra-op hypotension, but could lose long-term benefits and risk withdrawal hypertension.
Data on end organ damage is also conflicting. Increased AKI reported in some non-cardiac surgeries, but varied results in cardiac surgery.
A significant 2015 VA study found, in patients whose AAB was withheld pre-op, delaying restart past 2 days post-op was strongly associated with increased 30-day mortality, especially younger patients, highlights the balance.
This refractory hypotension is sometimes called vasoplegic syndrome, VS, defined as unexpected refractory hypotension, MAP 50 milliliter Hg, high cardiac index, 2.5 eliminabino, low SVR despite adrenergic vasopressors, Most common in cardiac surgery, 8–10%, but up to 50% in patients on AABs. Mortality in cardiac patients with persistent postoperative hypotension approaches 25%. Very serious. Proposed mechanism, depression of the 3BP support systems. Sympathetic, RAS, and vasopressin. Anesthesia depresses sympathetic. ADs inhibit RAS, leaving only vasopressin, which may also be impaired.
Other proposed mechanisms: cytokine-mediated relaxation, receptor downregulation, cell hyperpolemization, endothelial injury. Conventional VS therapies: decrease anesthetic, volume expansion, phenylephrine, ephedrine, high doses often needed.
Escalated therapy. Norepinephrine, epinephrine, dopamine if initial therapies fail. Vasopressin, rescue. If catecholamines ineffective, vasopressin may work. 0.5, 1.0 unit bolus, then infusion. Methylene blue, last resort. Suggested when others fail. Interferes with NOC-GMP pathway, inhibiting vasodilation. Dosed carefully. Given these risks, the prudent practice is widely adopted. Withhold the AAB the morning of surgery, restart immediately post-op.
This is a perfect example of why this deep dive is crucial, not just memorizing drugs, but understanding complex physiology and critical perioperative decisions.
And it raises the question, how do we balance the long-term benefits of these foundational meds with the immediate acute risks in the dynamic surgical environment? A constant challenge.
Let's turn to cardiac glycosides, characterized by digitalis preparations. With a 2-century history in treating CHF, digoxin is the main one.
Their primary inotropic effect comes from binding the alpha subunit of the NAC ATPase, sodium pump, in cardiac cells. This inhibits sodium-potassium exchange, increasing intracellular sodium, which decreases calcium exchange, resulting in higher intracellular calcium during systole. Augments contractility.
They also have electrophysiological effects, enhancing vagal tone, prominent, slowing heart rate, prolonging AV conduction. This vagal effect made digitalis historically useful for controlling ventricular response in atrial tachyarrhythmias, slowing AV node conduction.
But their current status, used as both antiarrhythmic and inotrope, has significantly decreased with more efficacious and safer drugs available.
A major reason is their narrow therapeutic index, small difference between therapeutic and toxic doses, high variability, serious side effects.
Digitalis toxicity is critical to understand. Electrolyte sensitivity. Hypokalemia greatly enhances digoxin effects. Therapeutic level can become toxic. Hyperkalemia has the opposite effect, also mediated by the P-glycoprotein transporter, arrhythmias. All known arrhythmias attributed to digitalis toxicity. Under anesthesia, first sign is often PVCs. Other signs: nausea, vomiting, diarrhea, headache, fatigue, colored vision. Monitoring. Close electrolyte monitoring needed, especially with pre-op bowel prep. Calcium contraindication. Calcium administration is contraindicated in digoxin patients' risk of cardiac arrest. Pre-op assessment. Serum potassium and digitalis levels can be monitored preoperatively in select patients.
What's fascinating is how a drug with such a long history has evolved as we understand its intricate mechanisms and significant risks, a lesson in pharmacological progress.
Absolutely. And it raises the question, what can we learn from digitalis about rigorous monitoring and individualized care, even with classic meds? Nuances matter profoundly.
Now, let's transition to how pharmacological advances have transformed perioperative care for patients with cardiovascular diseases. It's remarkable progress.
Right. Past decades were difficult, limited options, often just symptomatic therapy. Now, a vast array of cardiac drugs, improved anesthetic sophistication, extensive monitoring allow appropriate treatment, continuing the patient's specific care plan. The anesthetic process can now safely continue individualized care management. Risk classification systems, ACCAA, ESC, help predict poor outcomes based on patient and surgical risk.
Let's look at specific conditions, starting with congestive heart failure, CHF.
The prevalence is staggering. 40% over 85 have it, 8 million Americans projected by 2030. Leading cause of hospitalization over 65, 25% 30-day rehospitalization risk, 10% 30-day post-discharge mortality. While survival improved, absolute mortality is still 50% within 5 years.
Strikingly, CHF is the only major cardiovascular disorder increasing in prevalence. Annual cost, $40 billion. Fortunately, hospitalization and mortality rates seem to be declining recently, possibly due to aggressive intervention.
However, CHF remains a major independent predictor of adverse perioperative outcomes in non-cardiac surgery. Mortality estimates: 10% elective, up to 30% abdominal surgery, up to 76% in CHF patients with renal failure needing emergency surgery. Devastating.
A key insight from a multi-center study: Worsening preoperative heart failure significantly increased postoperative morbidity mortality, even controlling for comorbidities. And patients were more likely to suffer respiratory, renal, infectious complications than purely cardiac ones.
CHF is a complex syndrome from any structural functional disorder impairing ventricle filling ejection. Involves ventricular remodeling, chamber dilates, hypertrophies, becomes more spherical, and hormonal physiological alterations. Activation of neurohormonal systems like RAS is crucial in remodeling and progression.
Treatment is complex, tailored to age, disease state, concurrent disorders, usually polypharmacy, triple therapy, ACE inhibitors, beta blockers, diuretics, often statins, other agents, digoxin, ARBs, nitrates, aldosterone, hydrolysine, sometimes mechanical support devices.
Perioperatively, providers manage all severities. Goals range from preventing progression to surviving emergencies. Regional nerve blocks considered, but patients may have trouble lying flat. No single general anesthetic technique proven superior.
Invasive arterial BP monitoring and transesophageal echo, TEE, are incredibly useful for guiding intra-op decisions and fluid management. Real-time insight.
T helps diagnose causes of hypotension, inadequate volume, worsening function, or vasodilation. Allows targeted intervention. Drugs commonly used intraoperatively. Inotropes, PDE inhibitors, diuretics, vasodilators.
What stands out to you about the sheer prevalence and complexity of managing CHF patients perioperatively? It's daunting, but essential.
If we connect this to the bigger picture, it underscores the need for a truly holistic approach, considering all body systems affected by heart failure. Let's turn to arrhythmias. Serious arrhythmias needing intervention during general anesthesia are relatively low, about 1.6% in one large study.
Surprisingly low, right? Considering the factors. Most anesthetics are cardiac depressants, antiarrhythmic, but polypharmacy plus anesthetics can cause interactions. Add the stresses of surgery and anesthesia, you'd expect effects on rhythm.
Postoperatively, it's different. 30–40% after cardiothoracic surgery. Post-op AF, most common. Non-cardiothoracic. 4–20% depending on surgery type. Bradyarrhythmia is common after cardiac surgery, often early post-op, related to vagal tone fluctuation from injury edema.
Managing perioperative atrial arrhythmia depends on hemodynamic effect. First step, eliminate precipitating factors, electrolytes, hypoxia. Beta blockers significantly reduce AF risk up to 61%, so routine admin after cardiac surgery is standard for prevention. Sustained ventricular arrhythmias are uncommon, 1–3%, usually within the first post-op week.
New pharmacologic and non-pharmacologic approaches are emerging. New drugs, implantable cardiac devices, ICDs, ablation therapy. Antiarrhythmic drug use in the U.S. is actually declining due to increasing use of ablation and ICDs, a shift towards intervention.
Causes of intraoperative rhythm disturbances are varied. Age, structural heart disease, drug toxicity, hypoxia, hemodynamic instability, stress, electrolyte imbalance, surgical stimulation, etc.
Goals of drug therapy during anesthesia. Treat immediate hemodynamic problems, prevent progression. Treatment similar to non-operative setting, but therapies must be carefully titrated to avoid proarrhythmic or hypertensive outcomes.
Critical cautionary points before using antiarrhythmics. 1. Explore the cause before treating. Cardiology consult if possible. 2. Verify adequacy of ventilation, anesthesia depth, acid base, fluid electrolyte balance before formulating therapy. 3. Multiple drugs, potential for unexpected interactions. 4. ECG monitoring during surgery is suboptimal for complex diagnosis, but disturbances compromising stability must be addressed.
We classify antiarrhythmics, Vaughan-Williams classes, etc., and treat common arrhythmias based on characteristics, but always with those cautions in mind.
This raises an important question. With so many causes, how does the provider quickly diagnose the underlying issue during a procedure? It highlights their skill.
Hypertension, a major health problem affecting 78 million Americans, leads to MI, stroke, renal failure, death if untreated.
Updated classification, 2017 ACC-AH, optimal 20 CAD, elevated 120, 12980. Stage 2 redefined.
Vast number of drugs available. Main classes.
Yeah.
Diuretics, CCBs, ACE inhibitors, ARBs, beta blockers often included, but not always preferred first line.
JNC 8 recommendations for initial treatment. ACI, ARB, CCB, or thiazide for non-Black population, including diabetics. For Black population, including diabetics, CCB or thiazide initially. For CKD, ACEI or ARB recommended.
Many patients need 2 or more drugs. Reducing BP to goal is most important, specific combo less so. Unfortunately, BP remains inadequately controlled in over half of U.S. patients.
Perioperative BP management is ongoing. Many drugs available to decrease BP. Improved monitoring techniques make control almost routine.
Significance varies. Mild, moderate hypertension, probably minor risk. More severe episodes pose greater risk. benefit from acute therapy plus long-term follow-up.
Common causes of perioperative hypertensive episodes: emergence from anesthesia, pain, airway stim, hypoxia, shivering, bladder distension, withdrawal from meds, intra-op vasopressors.
Antihypertensive safe during pregnancy. Central alpha agonists, methyldopa drug of choice. Beta blockers, metoprolol preferred, caution with others with low birth weight. Diuretics, if pregestation salt sensitive, not for preeclampsia. Direct vasodilators. Hydralazine, parenteral drug of choice. Crucially, ACE inhibitors and ARBs are contraindicated in pregnancy due to fetal abnormalities death.
Okay, let's unpack the sheer range of options and critical decisions based on patient demographics and comorbidities. Complex puzzle.
What's fascinating is how tailored hypertension management has become. But this means the perioperative team needs intimate familiarity with each patient's unique drug profile. Let's talk coronary heart disease, CHD. 15 million Americans have it. Stable angina incidence, 500,000 a year. 8 million prevalent angina. While U.S. deaths declined, ischemic heart disease is leading cause of death worldwide, expected to accelerate due to obesity, diabetes, metabolic syndrome, high ED visit hospitalizations.
The anesthetic goal for cardiac compromised patients: hemodynamic optimization, tailored to patient surgery. No single technique superior. Core challenge: balance, avoiding increased myocardial work while maintaining proper perfusion. A delicate dance.
Usual pharmacotherapy. Nitrates, symptomatic relief, decrease O2 demand via preload reduction, redistribute flow. Beta blockers, cornerstone chronic prophylaxis, decrease demand via lower HRBP contractility. CCBs, effective variant angina beta blocker intolerant, reduce preload afterload, increase coronary flow.
Antiplatelet drugs. Aspirin inhibits cyclooxygenase, reduces coronary thrombosis. Clopidogrel substitute if contraindicated. Essential.
Statins, HMG-CoA reductase inhibitors. Documented benefits: primary secondary prevention, thought to improve perioperative outcomes, reduce inflammation, stabilize plaque, compliance with antiplatelet statin therapy and vascular surgery, patients significantly improved long-term survival. Pre-op statin use associated with reduced cardiac mortality after elective CABG. Post-op discontinuation associated with increased in-hospital mortality.
Right.
Critical role.
Briefly, ACE inhibitors, useful CAD plus diabetes, other vascular disease, and ranolazine, adjunct, blocks late sodium current, reduces calcium overload. If we connect this to the bigger picture, managing CHD perioperatively is about optimizing hemodynamics while mitigating risks. Comprehensive care. Now, let's talk preoperative administration of cardiac drugs, the critical balancing act of continuing or withholding. Continuation is now largely routine practice, including aspirin.
Aspirin generally adds little bleeding risk to most procedures. Crucially, abrupt withdrawal can cause platelet rebound, prothrombotic state, risk of major adverse cardiovascular event. Therefore, recommended as lifelong therapy, generally should not be interrupted for CV disease patients.
However, the POISE-2 trial suggested aspirin perioperatively didn't change CV event risk, but did increase bleeding. Changed thinking.
A 2015 review suggested aspirin should not be administered perioperatively unless definitive guideline-based primary-secondary prevention indication exists. Exceptions where continuation may be warranted: closed space procedures, intracranial middle ear, posterior eye, intramedullary spine, possibly prostate surgery. For moderate risk patients on lifelong aspirin for guideline-based secondary, not primary prevention, continuation may be warranted.
Recent evidence-based recommendations for elective surgery. 1. Most patients on aspirin for primary prevention pre-op cessation is safe. Identify self-prescribers, can safely stop 7 days pre-op, allows platelet function return.
2. Patients on aspirin for secondary prevention without a stent. Safety of cessation unclear. Limited data suggests continuing might be prudent. High CV risk non-stented patients likely continue aspirin unless closed space eye bleed risk procedure. Recent ECS, ideally DIPT for 1 year, but urgent surgery proceeds with aspirin minimum. 3. Cerebrovascular peripheral arterial disease patients. Minimal prospective data, but observational guideline data suggests stopping pre-op aspirin associated with significant risk.
Let's discuss dual antiplatelet therapy, DAPT, and stents. Very common now. 600K stents annually U.S. growing. Non-cardiac surgery after stenting frequent.
DAPT, aspirin plus P2Y12 inhibitor like clopidogrel, is standard. Duration critical, 6 weeks BMS, 3 to 6 months post-MI, 12 months DES, some longer.
The 2016 SCAA guideline update on DAPT duration. A. Elective non-cardiac surgery delay, 30 days post-BMS, optimally 6 months post-DES. Risk of stent thrombosis if the APT stopped, bleeding if continued. B. If P2Y12 inhibitor must be stopped for surgery, continue aspirin if possible, restart P2Y12 inhibitor ASAP post-op. C. When surgery required on P2Y12 inhibitor, consensus decision among clinicians on risk of surgery versus stopping continuing therapy is useful. D. Elective surgery after DS may be considered after 3 months if risk of further delay, risk of stent thrombosis. E. Elective non-cardiac surgery should not be performed within 30 days post-BMS or 3 months post-DS if DAP will need to be discontinued. Strong recommendations.
General principle. Maintain antiplatelet therapy if surgical bleed risk low, often ambulatory. If not possible, continue aspirin. Individualized P2Y12 inhibitor management.
Specific exceptions for DAP discontinuation, high bleed risk, closed space procedures, possibly TUR or surgeries with massive bleeding difficult hemostasis.
We must reiterate, beta blockers and clonidine continuation perioperatively is essential due to severe withdrawal syndrome risk.
And briefly remind everyone, AC inhibitors, ARBs, the controversy, prudent practice, often withholding morning of surgery, restarting post-op. What's fascinating is the incredibly intricate balancing act, preventing major CV events versus mitigating bleeding risks, especially with complex antiplatelet regimens.
And this raises the question, how can you, the listener, as an informed patient or caregiver, actively participate in these critical medication discussions before surgery to ensure the best outcome? Understanding empowers engagement.
And that brings us to the end of this deep dive. We've navigated the dynamic landscape of cardiovascular medicine and anesthesia, explored intricate pharmacology, delved into evolving guidelines, and unpacked complex perioperative decision-making.
This comprehensive exploration has, we hope, equipped you with a detailed, nuanced understanding, empowering you to approach this information with the mastery of an elite professional.
So after unpacking such a dense and critical topic, here's a thought to mull over. As personalized medicine advances, how might individual genetic profiles one day revolutionize our approach to these complex drug interactions and perioperative medication management, moving beyond current generalized guidelines?